Okay, welcome. My name is Divine. I'm a fourth year medical student. Welcome to our fifth episode of Divine Intervention. Today we're going to be talking about cardiac physiology. And basically, my goal today is to use different scenarios to describe cardiovascular physiology concepts. Your board exams classically love to test these in the context of analysis questions where they give you like a scenario and either give you like arrows or give you a scenario and give you like answers, right? And you have to reason through your understanding of the physiology to get at to correctly answer many of these questions. So the goal today is to spend some time going over some common scenarios to buttress certain cardiovascular phase concepts. And as I go through the scenarios, I will spend some time going over like whatever equations underlie whatever is going on. Okay, and as we go along, we'll potentially have other cardiovascular physiology podcasts. And if you spot any errors or you have any questions, feel free to reach out at divineinterventionpodcasts@gmail.com, and I will try to put you through fairly quickly. Thank you. So slide 1A. So where are cardiac valves heard best? This one's pretty easy, okay? There are many mnemonics that lie out there. There's like apartment M and all physicians take money or whatever work floats your boats. But basically the thing you should think about is the A in apartment M stands for your aortic valves. You hear that best at the right upper sternal border. The P stands for your pulmonic valves. You hear that at your left upper sternal border. The T stands for your tricuspid valves. You hear those best at the left lower sternal border. And then the M stands for your mitral valve. You hear that best at the apex. The apex is defined as being in the fifth intercostal space in the midclavicular line. Okay? So, where are heart murmurs heard best? In general, heart murmurs mirror where the valves are heard best, right? So most mitral murmurs are heard best at the apex of the heart. Many aortic murmurs, like aortic stenosis, are heard best in the right upper sternal border. Many tricuspid murmurs are heard best in the left lower sternal border. Some exceptions to those rules, and I'll sort of give you some background for this. Like aortic, in fact, I guess I'll just give two examples, like aortic regurg and aortic stenosis. Like, why are they heard at their specific locations? To sort of give you, again, some context for understanding this. But one thing I will say is aortic regurg and in fact, you know what, let me just hold off. Let me talk about my reasoning first. So if we think about this, the left ventricle is on the left, right? It's on the left side of the heart, and the aorta takes off from the left ventricle. If you sort of think of it anatomically, it takes off from the left ventricle and goes rightward in the thoracic cavity. So a forward flowing murmur in the aortic valve, like aortic stenosis for example, should also flow rightward. That is why aortic stenosis is heard best in the right upper sternal border. On the flip side, if you have a backward flowing murmur through the aortic valve, that backflow of blood is from the aorta, right, which takes off to the right, back to the left ventricle. So that regurgitant murmur is heading backwards from the right side of the thoracic cavity to the left side of the thoracic cavity. That is why aortic regurgitation is heard best at the left sternal border. Okay, at the left sternal border, like think of it as more of the left lower sternal border. That's also where you hear hypertrophic cardiomyopathy pretty well. So the next question says a discussion of preload and afterload reducing maneuvers, right? So we'll talk about maneuvers that increase preload and decrease preload, and maneuvers that increase afterload and decrease afterload. The preload increasing maneuvers that commonly show up on exams are inspiration, right? So if you inspire, you decrease intrathoracic cavity, that increases venous return. Okay, so a decrease in intrathoracic cavity increases venous return. Another thing that could accomplish the same goal is squatting. When you squat, you compress, you cause venoconstriction, and that venoconstriction, remember your veins are capacitance vessels, so they hang on to blood. So when you venoconstrict, you increase venous return as well, because you're decreasing the capacitance of your veins. And we'll say some more things about that in a later slide. Another thing that could accomplish the same purpose is a leg raise. When you raise your leg, excuse me, when you raise your leg, you again send more blood back to the right side of the heart. So those are preload increasing maneuvers. Now, the big preload decrease maneuver you want to know is the Valsalvan maneuver. So in the Valsalvan maneuver, you basically like close your mouth and like try to blow out air. Okay, that increases the intrathoracic pressure, because your pressures are building up, because the air has nowhere to go, because you've basically closed off your airway. And if your intrathoracic pressures go up, your venous return goes down, because the pressures in your right atrium increase. Normally the pressure in your right atrium is like 0. So if that pressure goes up a few points, then that gradient that encourages blood to flow from your veins back to your right atrium decreases. So let's assume the pressure in your veins are like 15 and the normal pressure in your right atrium is 0. But for some bizarre reason, you perform a Valsalvan maneuver and the right atrial pressure becomes 5. That gradient goes from 15 to 10. And if you have a lower pressure gradient, if you're thinking about one of the laws we're going to talk about in a bit, a decrease in pressure gradient decreases flow. So the venous return actually goes down under those circumstances. Now, the afterload increasing maneuver, the big one I'm going to mention here is hand grip. Okay, so when you shake a person really hard for some bizarre reason, you're basically clamping down on their radial arteries, for example. And if you clamp down on the radial arteries, that decreases the radius. When the radius goes down, the total peripheral resistance goes up. So that increase in total peripheral resistance increases the afterload. And if the afterload increases, will have certain implications that we'll talk about shortly. And then the big afterload decreasing maneuver I'm going to mention here is the administration of amyl nitrate. So amyl nitrate is a very powerful arteriolar dilator, and when you dilate your arterioles, the afterload goes down. And if the afterload goes down, you can sort of begin to imagine that drainage of the left ventricle would increase. So now that we've talked about those different maneuvers and the pathophysiology behind each, let's talk about the effect of these maneuvers on murmur intensities. So this is a classic head scratcher for many people, and many people just say, you know what, I'm not going to bother to reason through this, I'll just go ahead and memorize it. The only problem is there are so many intricacies to this that if you have one misstep in your memorization, then you run into a lot of serious problems. So it's just much better to try to understand, and then on an exam you can very easily reason through these scenarios relatively quickly, because they're actually pretty easy. So there are 3 different kinds of murmurs, right? So there's stenotic murmurs. So this is the way I'm grouping them. I'm grouping them as either being stenotic, as being regurgitant, or as being a special case murmur. And the 2 special case murmurs I will talk about are the murmurs of mitral valve prolapse and hypertrophic cardiomyopathy. I think if you group these murmurs like this and know like one big rule for each kind of murmur, you're good to go. So stenotic murmurs, regurgitant murmurs, and special case murmurs. So what is the big construct you want to know for a stenotic murmur? A stenotic murmur will sound louder whenever there is increased flow across the stenotic valve. So increased flow across the stenotic valve makes the murmur louder. So what are the things that could increase flow across a stenotic valve? You could increase preload, right? Because if you increase preload, there will be more blood flowing. If you're bringing more blood to the heart, obviously more blood will flow through the valve. Another thing that could also happen is if you decrease afterload. So if you decrease afterload, it's like you're opening the roads that are distal to that stenotic valve so that there is more flow. So an increase in preload or a decrease in afterload makes a stenotic murmur sound louder. If you remember that singular concept, you can reason through whatever and you know the maneuvers I just talked about a few minutes ago, then you can know what would increase or decrease the loudness of a murmur, of a stenotic murmur. Okay? Now, for the regurgitant murmurs, the construct, the one principle you want to remember is that anything that puts more blood in the vessel or the structure distal to the regurgitant valve will make the murmur sound louder. So what do I mean by that? For example, if a person has mitral regurgitation, the involved valve is the mitral valve. The distal vessel or structure, if you may, is the left ventricle. Anything that puts more blood in the left ventricle will make the mitral regurgitation murmur sound louder. Okay, so anything that will increase preload, right? If you increase preload, you will increase your left ventricular and diastolic volume. You're putting more blood in the left ventricle in the process of filling. Another alternative is to increase afterload. If you increase the afterload, you are decreasing drainage of the left ventricle. And if you decrease drainage of the left ventricle, there will be more blood in the left ventricle. If there's more blood in the left ventricle, as the left ventricle is contracting, there'll be more feet stuck, if you may, to go back through the regurgitant valve. So you have a worsening of the regurgitation across the mitral valve, so you get a louder murmur. So that's the big construct you want to know with regards to your regurgitant murmurs. And as an aside, the thing I will say is the same rules apply for a VSD. A VSD is basically a kind of regurgitant murmur. The only difference is that the regurgitation is not across a valve, it's across a septal defect. So anything that increases preload or increases afterload, just like we said for mitral regurg, for example, would increase the loudness of a ventricular septal defect. Now, the special case murmurs, they're basically just examples of either stenotic murmur or regurgitant murmur with a small twist. Okay, they do not obey the general rules that apply to their close cousins, like the stenotic murmurs, as you'll see when I talk about hypertrophic cardiomyopathy, or regurgitant murmurs, as you'll see when I talk about mitral valve prolapse. Okay, so let's talk about the stenotic murmurs. The stenotic murmur close cousin special case first. That's hypertrophic cardiomyopathy. Okay, again, it's a stenotic murmur with a twist. The big construct you want to remember here is that anything that increases the volume of blood in the left ventricle makes the murmur of hypertrophic cardiomyopathy sound softer. Okay, anything that increases the volume of blood in the left ventricle will make the murmur of hypertrophic cardiomyopathy sound softer. Now, what's the pathophysiology behind that? The thing is, whenever you have an increased volume of the left ventricle, that pulls the anterior mitral valve leaflet away from the left ventricular outflow tract. When you pull that anterior mitral valve leaflet away, you relieve the obstruction. And if you relieve the obstruction, you have easier flow. If you have easier flow, you have a softer murmur. So anything that increases preload, right? An increase in preload will increase your left ventricular and diastolic volume, so your left ventricular volume goes up, or anything that increases afterload will make the murmurs softer. The murmur of hypertrophic cardiomyopathy softer. Remember that the HCM murmur is heard best at the left sternal border. Okay, if you see me say left sternal border, just think of it as a region just above the left lower sternal border. Okay. Now, the other special case murmur is the mitral valve prolapse. The murmur of mitral valve prolapse is a regurgitant murmur, again, but it has a twist. The construct you want to keep in mind, the one central principle you want to remember, is that anything that increases the amount of blood in the left ventricle will make the murmur of mitral valve prolapse softer, not louder. Okay, remember we said for mitral regurg, other regurgitant murmurs, anything that increases the left ventricular blood volume will make the murmur louder. That's not the case for mitral valve prolapse. It actually does in fact make the murmur softer. And I will encourage you to look at the diagram I have in the slide. That will also sort of make that make some more sense. You basically make the valve leaflets overlap better when there is more blood in the left ventricle, and with that better overlap, you have less regurgitation. So anything that increases preload or decreases or increases afterload will make the murmur of mitral valve prolapse softer. Okay, and remember the association of mitral valve prolapse with like autosomal dominant polycystic kidney disease and Marfan syndrome as well. Okay, So now that we've talked about those constructs, you should be an expert on these murmur maneuvers if you just know what maneuvers do to preload and afterload. So next slide. So how does the murmur respond? So this is just me trying to torture you a little bit more, but just to really make sure you have this concept down. How does the murmur response to an afterload increase vary between mitral regurgitation and mitral valve prolapse? Okay, so again, if your afterload increases, there'll be more blood in the left ventricle. More blood in the left ventricle makes a mitral regurgitation murmur louder because there's more feedstock to regurgitate across the aberrant valve. But in mitral valve prolapse, more blood in the left ventricle makes the murmur softer because by having more blood in the left ventricle, you have better overlap of the malpositioned, if you may, the malpositioned mitral valve leaflets, and by having better overlap, you will have less regurgitation. Now, the next one says, how does the murmur response to a preload increase vary between aortic stenosis and hypertrophic cardiomyopathy? If you have an increase in preload, you'll have an increase in the left ventricular and diastolic volume. That will make the murmur of aortic stenosis louder because you have more blood, more turbulence across the stenotic aortic valve. On the off side that you have, if you have an increase in preload for hypertrophic cardiomyopathy, again, that will also increase the left ventricular and diastolic volume. But by having that increase in volume, you basically move the anterior mitral valve leaflet. That's a big buzzword you want to remember. You basically remove the anterior mitral valve leaflet away from the left ventricular outflow tract. So you relieve the obstruction. So because there's no more obstruction, the murmur doesn't sound as loud anymore. So an increase in preload makes the murmur of hypertrophic cardiomyopathy sound softer. And again, the descriptions of those murmurs are the same. They're like systolic ejection murmur, crescendo decrescendo pattern. That is literally the description of HCM and aortic stenosis. But one, the response to preload can help you make that differentiation. Two, the region where those murmurs are heard best will also help you make that differentiation. We said that the murmur of aortic stenosis is heard best at the right upper sternal border, but the murmur of hypertrophic cardiomyopathy is heard better at the left sternal border. Okay, again, that's a region that's just above the left lower sternal border, if you may. Okay, so slide 2. So keyword number 2, right? So heart rate changes with hydralazine administration, right? So if a person takes hydralazine is a powerful arteriolar dilator, right? So if you dilate the arterioles, what happens to your systemic vascular resistance? It should go down. Because remember, your arterioles are resistance vessels. So if the SVR goes down, your baroreceptors, for example, your baroreceptors are the carotid sinus, they sense a lower blood pressure. And when they sense a lower blood pressure, you have a decreased firing of those baroreceptors. That decreased firing activates your sympathetic nervous system in the brain, okay? And as you activate that sympathetic nervous system, you have a big sympathetic discharge, okay? So you release more norepinephrine, for example. And that norepinephrine can go and act on beta-1 receptors, and that will increase the chronotropy of your heart because you're increasing the speed of conduction through the AV node, okay? So your heart rate actually goes up when you administer hydralazine. That's why classically, that's the concept known as a reflex tachycardia. To reduce the chances of that happening, if you're giving a person hydralazine, you could also give them a beta blocker, okay? Like metoprolol, for example, to blunt the reflex tachycardic effect you get from the baroreceptor response, okay? Now, the initial management of a relatively stable patient who has a narrow complex regular tachyarrhythmia. So if you see this buzzword, narrow complex regular tachyarrhythmia, what are you thinking about? Well, I hope you're thinking about an SVT, a supraventricular tachycardia. Okay, an SVT, if a patient is relatively stable, the first step in management is to do some kind of vagal maneuver. Okay, some kind of vagal maneuver. Remember the construct I said with the first scenario. I said that whenever you have decreased firing of your baroreceptors, that causes an activation of your sympathetic nervous system. If you massage a person's carotids, for example, that's one kind of vagal maneuver. Okay. or you perform a Valsalva, right? Or remember, Valsalva increases intrathoracic pressures, so that can also sort of compress on your carotids, if you may. Compression of the carotids causes increased firing of your baroreceptors, okay? And if your baroreceptors in the carotid sinus fire more, okay, that will cause a decrease in the sympathetic response and an increase in the parasympathetic response. That increase in the parasympathetic response through muscarinic receptors can slow down conduction through the AV node and break the supraventricular tachycardia, okay? And while we're on this, remember we have baroreceptors. The aortic arch, for example, is a kind of baroreceptor, okay? Although it's also a chemoreceptor. And an easy way to remember that is just remember your ABCs, okay? Aortic arch, that's your A, has baroreceptor function, that's your B, and chemoreceptor function, that's your C, okay? So ABC, aortic arch, baroreceptor, and chemoreceptor. And the chemoreceptor, remember the aortic arch is outside the central nervous system. So the chemoreceptors that exist in the aortic arch are known as peripheral chemoreceptors. And remember that chemobaroreceptor information is relayed through cranial nerve 10, your vagus nerve. Okay, that's a commonly tested board concept. Now, your carotid sinus, you'll find it around your carotid arteries, close to the bifurcation. That's primarily a baroreceptor. Okay, in fact, it's probably the more sensitive baroreceptor that we find in the body. Okay, that's the thing that explains what the different scenarios I talked about with taking hydralazine or massaging the carotid vessels. Now, another receptor related to all this business we're talking about is the carotid body. The carotid body is more a chemoreceptor, and an easy way to remember that is just remember like ordering a CBC. So carotid body, chemoreceptor, CBC. Okay, so it's a chemoreceptor, and because it's placed more in the central nervous system, remember the carotids traverse the neck and begin to go into the head. Think of them as being think of those as also being peripheral chemoreceptors. Think of those as being peripheral chemoreceptors. It so happens that they're actually central chemoreceptors in the medulla, so I don't speak on that. Okay, so your chemoreceptors, if your pH goes down, or your partial pressure of carbon dioxide goes up, or your partial pressure of oxygen goes down, right? So again, think about this. If your PO2 goes down, you become hypoxic. If you're hypoxic, your PCO2 will go up. If your PCO2 goes up, remember, CO2 is an acid anhydride, if you're thinking back to college chemistry, and that CO2 dissolves in water and in your bloodstream, if you may, and lowers your pH. So all those things are indicative of hypoxia, and that hypoxic response is usually followed by an increase in your parasympathetic discharge. In your sympathetic discharge. Okay, your sympathetic discharge. An increase in your sympathetic discharge can cause like hypertension, for example, okay, or increase your cardiac contractility, increase your heart rate, and things like that. So now that we understand these different receptors, let's talk about the brain's response to ICP increases. Okay, so if your intracranial pressure rises, you begin to compress on the vessels that feed the brain. Okay, you begin to compress on your cerebral vessels, and when you compress cerebral vessels, the perfusion of the brain begins to go down, which is not ideal. So what do I mean by perfusion of the brain? There's this equation that relates the cerebral perfusion pressure, I believe you'll find this in the neuro chapter of first aid, to the mean arterial pressure and your intracranial pressure. So your cerebral perfusion pressure equals your MAP, your mean arterial pressure, so basically your blood pressure, minus your intracranial pressure. So if you have an increase in your intracranial pressure, and your mean arterial pressure is staying constant, your cerebral perfusion pressure begins to go down. And you can begin to run into trouble like cerebral ischemia and ultimately like infarction, which is not ideal. So, one way your body responds to that increase in ICP is to try to increase your MAP, because by increasing your MAP, your CPP, your cerebral perfusion pressure, will go up. Okay, so you have a massive sympathetic discharge in the setting of an increase in ICP. That massive sympathetic discharge increases your cardiac contractility and basically makes your blood pressure go up. Okay, and remember, if you also have a very good sympathetic discharge, if you're releasing a lot of norepinephrine, you're acting on alpha-1 receptors that we find on blood vessels. That alpha-1 effect on blood vessels will cause vasoconstriction. That will increase systemic vascular resistance, and that will increase mean arterial pressures. Okay, so you get an increase in blood pressure, so that means you get a hypertension, and again, that's to increase your CPP. But that increase in blood pressure, right, as that blood pressure increase, right, so think of this as like time-lapsing events. You have that initial sympathetic discharge because you have ischemia of the brain, increase the intracranial pressure because you're compressing on your cerebral vasculature. That hypertension will be sensed by your bioreceptors, for example, at the carotid sinus. When your carotid sinus senses those increased blood pressures, okay, you have increased firing of your bioreceptors. If you have increased firing of your bioreceptors, you will have a massive parasympathetic discharge, okay? And that massive parasympathetic discharge can slow conduction through your AV node, if you may. In fact, if you're thinking of this with regards to the pacemaker potential, you're actually decreasing the slope of phase 4 of the SA nodal potential. And if you decrease that slope, you have a bradycardia. Okay, so we said that the first thing that happens in the setting of increased ICP is you become hypertensive. That's step 1. And if you really want to be like super nitpicky about this, you actually get a tachycardia as well. Initially. But when your baroreceptor response kicks in, the predominant effect that happens after you have the initial hypertension is the bradycardia, because you have that massive parasympathetic discharge in phase 2, if you may, of this response. So if you think about it, what is this thing I'm mentioning? If you said, oh, a person has bradycardia, a person has hypertension, and let's just tag on irregular respirations with this. What is this triad called? Well, I hope you're thinking of this as the Cushing's triad of increased ICP. Okay, the mechanism behind the irregular respirations have not exactly been worked out, but the bradycardia and hypertension actually do make sense. In fact, if you remember me saying that the massive parasympathetic discharge is what causes the bradycardia, that can also sort of help you remember why you have peptic ulcers in the setting of increased ICPs, right? So a Cushing's ulcer. A Cushing's ulcer is the kind of peptic ulcer you get with high ICP, because again, if your ICP is very high, your baroreceptor response causes a massive parasympathetic discharge through cranial nerve 10. Remember, your parasympathetic system can activate G cells in the GI tract, and those G cells, when they're activated by gastrin releasing peptide, right, you make more gastrin. And one of the things gastrin could do is gastrin could go and talk to your parietal cells. It could stimulate them through CCKB receptors to release more acid. Okay, and if you have hyperacidity, you could get ulcers. Remember, another thing that G cells do, right, after they secrete gastrin, that gastrin can go and activate enterochromaffin-like cells. Those cells can release histamine. Histamine can act on histamine H2 receptors in the GI tract, and again, that can cause parietal cells to release more acid. Okay, so that's the potential pathophysiology behind a Cushing's ulcer. Okay, so those are the different responses of the brain to increases in intracranial pressures. Now, question 3, dobutamine and cardiac output, right? So how does dobutamine work? Dobutamine is a beta-1 agonist. Okay, so because it's a beta-1 agonist, it would increase your cardiac contractility. Okay, so that's an inotropic effect. It also increases your heart rate. That is a chronotropic effect. Okay, so your cardiac output will go up because your heart rate is going up, and your stroke volume is also going up because your cardiac contractility is going up with dobutamine. Now, the effects of malerenown on cardiac output, right? So malerenown, how does malerenown work? Malerenown is a phosphodiesterase 3 inhibitor. It inhibits PDE3, and phosphodiesterase, we already know that this is the enzyme that breaks down cyclic AMP to AMP. Okay. Now, let me teach you a quick construct here. An increase in cyclic AMP causes contraction of cardiac muscle. The mechanisms are, I'll let you go over that on your own. I'll talk about that in a later podcast. But the big construct here is an increase in cyclic AMP causes cardiac muscle contraction. An increase in cyclic AMP causes smooth muscle relaxation. So, big cyclic AMP increases cardiac contractility. Big cyclic AMP causes smooth muscle relaxation. So, if a person takes malerenown, PDE3 inhibitor, their cyclic AMP levels go up, what should happen to the cardiac output? It should go up because their cardiac contractility is increasing. Okay? Now, the systemic vascular resistance in these people should go down. And again, the reasoning behind that is, again, remember your blood vessels are all lined by smooth muscle. So if you cause smooth muscle relaxation because of elevated levels of cyclic AMP, you have a vasodilation that decreases your systemic vascular resistance. Okay? And if your cardiac output increased with malerenown, what's happening to your systolic blood pressure? It's actually going up. Your systolic blood pressure is a proxy for your cardiac output. In fact, whenever you get any MBME question or whatever that talks about systolic blood pressure, just always ask yourself, this scenario that was described to me, what happens to the cardiac output? If the cardiac output went up, your systolic blood pressure should go up. Okay? And on malerenown, we said your systemic vascular resistance is going down. If that is going down, what should happen to your diastolic blood pressure? It should go down. Okay, so again, think of your systemic vascular resistance as being a proxy for your diastolic blood pressure. So, any MBME question you get that talks about, oh, what happens to your diastolic blood pressures? Just reason it out in the context of SVR. Whatever happens to SVR will be what will happen to your diastolic blood pressure. So, when you're taking malerenown, you're exerting a positive inotropic effect on the heart, but on the flip side, you're also decreasing the SVR. Okay, so your systolic blood pressure is rising, positive inotropy. Your diastolic blood pressure is falling because of the vasodilatory effect of malerenown. In fact, some physicians refer to malerenown as an inodilator for this express reason. So, if your systolic blood pressure is going up and your diastolic blood pressure is coming down, what's happening to your pulse pressure? Remember, your pulse pressure is your systolic blood pressure minus your diastolic blood pressure. Your pulse pressure is actually going to increase on malerenown. Okay? You can also observe the same effect if a person is taking isoproterenol. Isoproterenol is a beta-1 and 2 agonist. Okay? By activating beta-1 receptors, you have an increase in inotropy. You have an increase in cardiac output, just like malerenown does. And then by activating beta-2 receptors, you cause a vasodilation. Because remember, again, beta-2 receptors are GS coupled. Okay, they're kind of G protein coupled receptor. If you activate that beta-2 receptor, GS is activated. You have an increase in adenylate cyclase activity. Your cyclic AMP activity goes up. Okay, and we said big cyclic AMP causes smooth muscle relaxation. Okay, that is why you get a decrease in SVR when you activate beta-2 receptors. Now, and on the flip side, again, if you activate beta-1 receptors, those are also GS coupled. You increase cyclic AMP, so you get more cardiac contractility. And if you even wanted to take that to like a very, if you wanted to keep making analogies with that, if a person is pregnant, is in labor, and you want to delay labor, you can give a beta-2 agonist, because as it so happens, your myometrium has a ton of smooth muscle. Okay, so you give a beta-2 agonist, you activate GS coupled receptors, your cyclic AMP levels go up, so you cause relaxation of the smooth muscle in the uterus. Again, if you also wanted to take this even further to your respiratory system, if a person has a history of asthma, okay, you give them albuterol. Albuterol is a beta-2 agonist. Okay, by giving a beta-2 agonist like albuterol, you activate a GS coupled receptor, your cyclic AMP levels go up, the smooth muscle in your airway relaxes, and you get a bronchodilation. If you wanted to make one more analogy, right, I promise, before we go on to the next step, if you gave a person theophylline, right, theophylline is a phosphodiesterase inhibitor. If you give a phosphodiesterase inhibitor, your cyclic AMP levels will go up. If your cyclic AMP levels go up, again, smooth muscle relaxation, you get bronchodilation. Okay, so hopefully these different examples sort of reinforce that concept for you. Now, Next question says calculating cardiac output, right? So there's many ways to calculate cardiac output. One way, the easy one, is cardiac output is heart rate times stroke volume. That's easy to remember, right? So if you increase your heart rate or increase your stroke volume, your cardiac output goes up. End of story. Now, the other equation that is somewhat less intuitive, but if you really thought about it, it's actually intuitive, is the fixed principle equation, where your cardiac output is equal to your VO2, and your VO2 basically means your oxygen consumption. So it's equal to your VO2 divided by the difference in O2 saturation between your veins and your arteries. Okay, so cardiac output is equal to VO2, or your oxygen consumption, right? So that's a direct relationship. Your cardiac output is directly proportional to your oxygen consumption. That should make sense. If you're consuming more oxygen because you're exercising, you'll have to increase your cardiac output to meet that demand, right? So that's easy. Now, in the denominator, on the other side of that equation, is the difference in O2 saturation, right? So if you're reasoning along with me, you can see that there is an inverse relationship between your cardiac output and the difference between your O2 sat in your arteries versus the O2 sat in your veins, right? So again, think about this. If your cardiac output is low, right? If you're just thinking purely mathematical, before we go all hardcore physiology here, if your cardiac output goes down, the difference in the O2 sats between your veins and your arteries should go up. Now, why does that make any sense? The reason that makes sense is that when your cardiac output is low, your tissues try to get more efficient at extracting oxygen from whatever blood is coming from the arterioles, because you're like, my cardiac output is low. I don't know when my next blood supply will come. So let me just try to take as much oxygen as possible, right? So if you're saving up more oxygen, there'll be less oxygen left at the end in your veins that are sending the blood back to the heart. Okay, that is why hypoxia. Actually, let me hold that secret back. I'll talk about that in an upcoming slide. Actually, okay. So a decrease in cardiac output makes your tissues extract more oxygen. Okay, and if you extract more oxygen, the amount of oxygen you'll see in your venule will be much less than the oxygen you see in the arteriole, compared to a more high cardiac output state. Okay. Now, and in a later podcast, we'll probably talk about why you have a decrease in the oxygen tension between your arteries and veins. So like that difference is decreased in a person that is septic. In a person that is septic, they have a very high cardiac output, right? If their cardiac output is high, if you're thinking in terms of fixed principle, you can see why that arterial oxygen versus venous oxygen difference is much smaller. But that's a more advanced concept. We'll talk about that later. Okay, that's more for like an ICU exam. Okay, now the mean arterial pressure. So how do you calculate the MAPS, right? So there are many ways of calculating your mean arterial pressure. There are many ways of doing that, right? So the equation that will probably help, and I'll flush this equation out some more in a later slide, is that your P is equal to your Q times R. Okay, P equals Q times R. So the Q, whenever they're referring to the cardiovascular system, is your cardiac output. The R, whenever they're referring to your cardiovascular system, is your total peripheral resistance. Okay, so your mean arterial pressure is equal to your cardiac output times your total peripheral resistance. Now, another formula for mean arterial pressure is just a formula that relates your systolic blood pressure and your diastolic blood pressure. The thing is, the heart spends more time in diastole, right? So the 2/3 number goes with your DBP, a 1/3 number goes with your SBP. Okay, so another formula actually for your MAP is your 1/3, like 1/3 of your systolic blood pressure plus 2/3 of your diastolic blood pressure. And then a final formula is your systolic blood pressure plus, I believe it's 1/3 your pulse pressure. Let me look this up. I knew this when I was preparing this slide. Now it's no longer there, but let me just look this up. Easy to look up. So pulse pressure and MAP. Okay, so let's look at the formula for this. Formula. Okay. Yep. So, that was actually correct. So your MAP is your diastolic blood pressure plus 1/3 your pulse pressure. Okay, and again, your pulse pressure is the difference between your systolic and diastolic blood pressures. Okay. And if you're more mathematically inclined and you sort of work out that 2/3 DBP plus 1/3 SBP, you will arrive at this third formula. Okay, so what is the one pediatric and one cardiac pathology that classically presents on exams with pulse pressure elevations? Okay. In terms of the pediatric pathology, I guess I should modify this to pediatric cardiac pathology. So pediatric cardiac pathology and one adult cardiac pathology that classically presents on exams with pulse pressure increases. The big pediatric pathology you want to know is the patent ductus arteriosus. Okay, it's a very specific finding on MBME exams. And then for adults, that's aortic regurgitation. Basically, the construct I will give you to easily remember this is whenever blood is flowing in, so normally blood should flow in one direction. Okay, let's just make that our construct. If blood begins to flow in two directions, I think of it as, I'm creating a new blood vessel. Okay, so if you may, I'm creating more options for that blood that got into the aorta to flow. And if you create more options, you're effectively decreasing systemic vascular resistance. If your SVR goes down, your diastolic blood pressure goes down, so your pulse pressure gets wider. Okay, so if you get any kind of MBME question where a person has a blood pressure of like 110/40, that is a super wide pulse pressure. Think of, if it's a pediatric question, think of patent ductus arteriosus. If it's an adult question, think about aortic regurgitation. Okay, think about aortic regurg. In fact, if you get an auscultation question and you see a wide pulse pressure, you probably don't need to burn time listening to the, at least if you're short on time, you can just very quickly say, pulse pressure is wide, it's one of these two problems, look at the age range, and you're good to go. Okay? Now, 3 common MBME strategies for increasing the cardiac output. Well, this is relatively easy. One strategy is you can increase the preload, right? So more preload will, according to the Frank Starling principle, that's coming up on a later slide, more preload increases your end diastolic volume, and if your end diastolic volume goes up, your stroke volume will go up. Okay. Another strategy is to increase the contractility. So if your end diastolic volume is not changing at all, or you just increase the contractility of the heart, okay, your cardiac output will go up as well, because increased contractility will increase your stroke volume. Another thing that could make that happen is to also decrease your afterload. Whenever you decrease afterload, you're increasing drainage from the left ventricle. Okay, so your stroke volume is going up, so your cardiac output goes up. And just as an addendum, if you're thinking of, I guess, molecular strategies for increasing the cardiac output on your exam in terms of contractility, the 3 molecular strategies I already talked about. Actually, I've talked about most of them already. If you have beta-1 stimulation of the heart, okay, beta-1 stimulation of the heart will increase cyclic AMP. That will cause increased contractility. Another thing that could happen is if you just increased cyclic AMP through a backhand mechanism, right, by, for example, giving a phosphodiesterase inhibitor, that increased cyclic AMP will increase cardiac contractility. Another thing that could increase cardiac contractility is to increase the intracellular calcium. Okay, so this is more what digoxin does. Okay, digoxin increases your intracellular calcium, and that increases cardiac contractility. So those are 3 high-yield molecular strategies for increasing cardiac contractility, right, or exerting, if you may, a positive inotropic effect on the heart. Okay, so let's go to question 4. So these ones should hopefully go by a lot quicker. So slide 4 says, what does an increase in venous return do to the end diastolic volume, the stroke volume, the cardiac output, and the end systolic volume? Okay, so if you have an increase in venous return, right, your preload is obviously going up. If your preload goes up, right, you're putting more blood in the left ventricle, your end diastolic volume should in fact go up. Okay, and according to the Frank-Starling principle, where if your end diastolic volume goes up, your stroke volume goes up, right? It means that as your EDV is going up from an increased preload, your SV goes up, okay? And because your cardiac output is heart rate times stroke volume, an increase in stroke volume will in fact increase your cardiac output, okay? But as a nitpicky point, your end systolic volume largely does not change according to the Frank-Starling principle if your heart is working just fine. Because yes, you put more blood in the left ventricle, right? So your end diastolic volume is going up, but your stroke volume is also going up proportionally, okay? And as your SV goes up proportionally, your end systolic volume does not necessarily change, okay? Although remember, if because I can imagine if you're like a very hardcore physiologist, you could say, Divine, yes, what you just said is true, but it's true to a point, and that is in fact true. And that true to a point will be illustrated on the next slide, because basically the Frank-Starling principle is, as you increase the length of sarcomeres, you're increasing the tension you're placing on those sarcomeres. As you increase the tension you're placing on those sarcomeres, you're actually squirting more blood out of the heart, so your stroke volume is going up. But if you look at the graph on the next slide, that you have that proportional relationship, and then you hit a max where there's no more change anymore, okay? So there's a certain length beyond which your cardiac contractility I just want to be physiologically accurate here. There's a certain length beyond which you've placed too much tension on your muscle, on your sarcomeres, that they do not let out any extra blood, okay? So at that point, your stroke volume will actually not be increasing, even if your preload is increasing, right? So if you put just way too much blood in the left ventricle, yes, your stroke volume will go up, okay? But at some point, your stroke volume will not go up in proportion to your end diastolic volume. So at that point, your end systolic volume could increase marginally, okay? But I'll just say in general, as your end diastolic volume goes up from increased preload, your stroke volume goes up, and your end systolic volume generally does not change, okay? If you want to go to step one, that's what you should take away. But if you want to think even deeper about it, at some point, your end systolic volume actually begins to rise. But that's not very relevant to our discussion today. Okay, so this is the Frank-Starling principle. So let's go to the next slide and talk about the relationship, okay? Because your friends at the MBME love to torture you with this. So if you look at, there are three graphs, okay, and I put my references in the last slide. But there are three graphs here. If you notice, as the venous return goes up, okay, your left ventricular end diastolic volume should go up, right? And if your LV-EDV is going up, that should also make sense that your LV-EDP should go up as well, okay? Because more blood volume should increase the pressures in the left ventricle, okay? And as you notice, as that is going up, okay, your stroke volume is going up. That's the Frank-Starling principle. And again, the reasoning behind that is, as you put more blood in the left ventricle, you're increasing the length of the left ventricle, you're placing more tension on the left ventricle, and that increase in tension, as the left ventricle snaps back in the process of systole, you're sending more blood out, okay? But notice that these changes are along one curve, Your friends at the MBME count on you to try to think about this in a relatively not prudent way. What do I mean by that? If you look at the second graph, right, you can see so red is the normal curve, okay? You can see some black lines going above. Basically, your slope is increasing, and you can see some black lines going below. Basically, your slope is decreasing, okay? Those slope increases are at constant left ventricular end diastolic pressures, okay? So if your preload is not changing, one way you can make the slope of the Frank-Starling curve higher is by increasing contractility, if you may. So giving a drug like digoxin or giving malerenown, for example, okay? Those things, if your preload is not necessarily changing, so if you're like, oh, my preload is being held constant, but wait, my stroke volume is increasing. The reason your stroke volume is increasing is because your cardiac contractility is increasing. So in that specific scenario, your end diastolic volume is not changing, because your preload is the same. Your stroke volume is increasing, okay? And because your stroke volume is increasing, your end systolic volume should go down, okay? Your end systolic volume should go down. So, why am I making a fuss about this? For the graph on the left, okay? For the very first graph on the left, we said that an increase in preload increases your end diastolic volume. And because of that increase in end diastolic volume, your stroke volume is going up. Okay, that is the Frank-Starling principle, but your end systolic volume is not changing as a rough approximation. Okay, but if a person has a constant preload, if the preload is not changing, your end diastolic volume does not change. The only thing that can increase your stroke volume in the context of a constant end diastolic volume is an increase in your cardiac contractility. At least for purposes of this graph that I'm describing. There are many other things that can do it, but let's keep things simple here. So an increase in contractility will increase your stroke volume in the presence of a not changing preload, or you can say not changing end diastolic volume or end diastolic pressure. Okay, that's a very important concept to understand. And in those cases, if your EDV is staying constant and your SV is increasing, it means that your ESV, your end systolic volume, should go down. Okay, so in the Frank-Starling mechanism, your EDV is increasing, your SV is increasing, but your ESV is staying constant. Contrast that with a constant EDV. Let's say you're like, oh, I'm just increasing contractility. You're not doing anything to your preload. Your EDV is staying constant, your SV is increasing, so your ESV is coming down. Okay, just one of those bizarre things that you want to make sure you understand. Okay, so an increase in the slope of the Frank-Starling curve occurs. It's not a Frank-Starling effect. That increase in slope is an effect of an increase in your contractility, as an example. Okay, if you're decreasing the slope, it's from a decrease in contractility, right? And you can get that if you're taking a class 2 antiarrhythmic, like a beta blocker, or a class 4 antiarrhythmic, like your non-dihydropyridine calcium channel blockers, like verapamil and diltiazem. Okay, very high yield to understand these things. And again, graph 3 just shows this Frank-Starling thing I mentioned. Remember, if you're looking at your pressure volume loops, on the very left at the bottom, you have your end systolic volume, right? Because that's after isovolumetric relaxation, okay? And then on the far right on the bottom, you have your end diastolic volume, okay? If you're increasing venous return, right, you see that red bulge, your end diastolic volume goes up, okay? And because the width of the vertical lines represents your stroke volume goes up, okay? But if you notice, because you're not changing, because the only thing you're changing is your preload, your end systolic volume is actually not changing, okay? Although that is not exactly true, okay? That is not exactly true, but go with that approximation for your exam. Okay, so slide 5. What is the mechanism behind the peripheral edema observed with the taking of hydralazine or a dihydropyridine calcium channel blocker? Okay, so if we think of blood vessels, right? So blood vessels have we have like arterioles that feed capillaries, and capillaries then feed venules. Okay, so it so happens that hydralazine, okay, and your dihydropyridine calcium channel blockers like amlodipine, felodipine, clevidipine, and all that fun stuff, okay, those drugs works very specifically by dilating precapillary arterioles. Okay, so they dilate the arterioles that come before capillaries. If you dilate those arterioles that come before capillaries, it should make sense that the hydrostatic pressures in your capillaries should increase. Okay, and because again, more blood is going to capillaries, right? So if you have an increase in hydrostatic pressures in capillaries, right, you'll have more extravasation of fluid. If you're thinking of the Starling forces you learn when you study renal, an increase in your hydrostatic pressure in capillaries will cause more fluid extravasation. Okay, so if we know that an increase in hydrostatic pressure causes an increase in fluid extravasation, which causes peripheral edema, it should then make sense that whatever treatment strategy we employ should aim to decrease those hydrostatic pressures. And we know that venules come distal to capillaries, right? So if we give something that selectively dilated those venules, we would draw more blood away from those capillaries, we would decrease the hydrostatic pressures in those capillaries, and we could potentially fix the peripheral edema. Okay, so it so happens that angiotensin 2 is a powerful constrictor of postcapillary venules. So if you gave an ACE inhibitor, which will decrease your angiotensin 2 levels, or you gave an ARB like losartan, which will block the angiotensin 2 type 1 receptor, you would have dilation of those postcapillary venules. When you have dilation of those venules, you have a decrease in hydrostatic pressure, and you can fix the peripheral edema. Okay. Now, next slide, slide 6. What is the pathophysiology behind the peripheral edema observed in a 30-year-old female with a BMPR2 mutation, right? So I stole this from pulmonology, okay? If you see a 30-year-old female with a bone morphogenic protein receptor 2 mutation, okay, I really hope you're thinking about pulmonary arterial hypertension, okay? Pulmonary arterial hypertension. Remember, your pulmonary arteries drain the right side of the heart. So if you have pulmonary arterial hypertension, you'll have an increase in your right-sided heart pressures, and because all the veins drain into the right side of the heart, you'll have an increase in venous pressures. An increase in venous pressures will cause more fluid extravasation, and then you can get peripheral edema with that. Okay, so that's the pathophysiology there. Now, next slide. As blood flows through the vascular tree, where do we record the biggest resistance or pressure drops? Okay, so the biggest resistance / pressure drops actually across arterioles. Okay, in fact, that's why your arterioles are called resistance vessels. So you're like, why is this true? Well, this is true because arterioles have a very large, I did not say the largest, I just say they have a very large cross-sectional area. Okay, so like your aorta has like a big radius, but you have just one aorta. You have millions of arterioles. Okay, so if you take all the radii of those individual arterioles and add all of them up, okay, you have a very big cross-sectional area. Okay, and a very big cross-sectional area does in fact cause pressure decreases. Okay, because again, if you think to let's see, what's the equation I'm trying to remember here? So P equals Q times R. So P equals Q times R. If your resistance goes up, right, your pressures should go up. That's one equation. The second equation is an equation that relates to, I believe, Poiseuille's law, where the resistance in a vessel, okay, the resistance in a vessel is proportional to the viscosity multiplied by the length of the vessel divided by the radius of that vessel to the 4th power, right? So if a person has, if your arterioles, if you take all the radii and add them all together, the radii of your arterioles are very large taken together, okay? And as that radius goes up, because radius is inversely proportional to resistance to the 4th power, the resistance goes down. And from the first equation I mentioned, if your resistance goes down, right, your pressures should go down as well, okay? So you actually have the greatest pressure drops across arterioles, because your biggest pressures, like your arterioles feel a lot of the, like your beginning arterioles, if you may, feel the pressures that are coming from your aorta, right? So that's a very high pressure. But after that blood has percolated all through those arterioles, you have a very big pressure drop because, again, you're going through a much wider cross-sectional area, okay? Now, so I've explained the pathophysiology behind that. And again, that should make some sense because, again, you don't want to have super high pressures in capillaries so that you can have like a more harmonious exchange of nutrients and oxygen, if you may, okay? You don't want your hydrostatic pressures to be so high that those are the only pressures that are working at the level of your capillaries, because if those are the only pressures that are working, you have great phenomenal filtration, okay? But the problem you'll run into is you'll have very crappy reabsorption across those capillary walls, okay? So you don't want super high pressures in your capillaries. You also don't want to blow out your capillaries and get peripheral edema, Okay, so next slide. What are the vessels with the largest, right? So I did not say the vessels with large cross-sectional areas. Now I'm asking about the largest, okay? The vessels with the largest cross-sectional areas in the cardiovascular system are your capillaries, okay? Your capillaries have a very high cross-sectional area, okay? And if you go back to fancy college physics, I know some of you will be like, oh man, I thought I would forget and drop all these things forever after I'm done with pre-med. Well, sorry, that's not the case. Although we're not going into big detail here. But if you remember from college, right, like flow rates are equal to your area times velocity. Okay, so I already said that the area in your capillaries are very, very big. Okay, now if the area in your capillaries are very, very big, what would that do to your flow velocity? Assuming the flow rate, because remember your blood vessels and your heart, they are all one continuous system in series, right? So the flow rate is equal everywhere. So if the flow rate is equal everywhere, and we said that capillaries have the biggest cross-sectional area, what should happen to the velocity of blood flow in capillaries? It should be low. And again, that is a good thing, right? Because by having that reduced velocity, okay, you have better flow. You have slower flow in your capillaries, and that slower flow in your capillaries sort of gives you enough time to exchange nutrients, gases, and waste products, okay? But if blood is flowing way too fast, you don't have that exchange of nutrients and oxygen, and that is not ideal. That is not what you want if you're a human being, okay? So, next slide. What are the vessels with the largest capacitance in the cardiovascular system? Okay, the vessels with the largest capacitance in the cardiovascular system. Well, those are your veins. Okay, your veins have the largest capacitance. Now, what is the underlying pathophysiology? The underlying pathophysiology behind that, and I'm sure you've taken some kind of histology class in med school. If you look at the walls of veins under microscopy versus the walls of arteries under microscopy, veins have very little in the way of elastic fibers. Okay. And because they have very little in the way of elastic fibers, that means they have very low elastance. If they have very low elastance, they should have very high compliance. You may be saying, Divine, wait for a moment. What do you mean by that? I thought that being more compliant meant I was more elastic. That is what your friends at the MBME want you to think. Do not think in that way. Okay? Elastance is not a measure of how stretchy you are. Okay, elastance is a measure of how well you snap back after you've been distended. Okay, so if something is very compliant, it means that thing distends very well. If you're very good at distending, it means you're very crappy at snapping back. Okay, so any vessel or any structure that has very high compliance actually has very low elastance. Okay. In fact, compliance, think of compliance as being equal to a change in volume over a change in pressure. We'll make a bigger fuss about this when I do some pulmonary podcasts. And if elastance is the reverse of that, it should stand to reason that elastance is a change in pressure divided by a change in volume. Okay? So again, because your veins have very little in the way of elastic fibers, they have a very small elastance. Because they have a very small elastance, they have a very high capacitance, or compliance if you may. Okay? And because they have a high compliance, they have a very high capacitance because they can store more blood. Okay? They can store more blood. Now, so that's the underlying pathophysiology, right? So why do nitrates work in the setting of angina? Okay? The reason nitrates work is nitrates are venodilators. Okay? Venodilators. When you dilate veins, okay, you're increasing their capacitance their compliance some more. Okay, so you're retaining more blood in your veins, and if more blood is being retained in the veins, what happens to your preload? It goes down. If your preload goes down, there is less blood that's in the heart. Okay, and because there's less blood in the heart that's in the heart, you're not stressing the heart as much. Okay, so you have a decrease in myocardial oxygen demand because it doesn't have to pump as much blood. So your symptoms of angina are reduced. Okay, it's not necessarily because you're dilating coronary vessels. No, that's not really the pathophysiology. The pathophysiology is that because think about it, right? If you have let's assume you're being paid $50,000 a year, okay, and you have a certain lifestyle with that, and then let's say something bad happens in the economy, and your salary plummets to like 10 grand a year, okay. If you're earning 10 grand a year, if you were still trying to keep up with your previous lifestyle, right, so if you're trying to keep up with the Joneses basically, you'll sort of have a mismatch there. You begin to have like painful living conditions, okay. But if you adjust your lifestyle downwards, like you move to a smaller house, you buy a smaller car that consumes less gas, then you're pretty much fine. Even if you have a decrease in the flow of money towards you, you don't have any problems because your demand on that money has decreased. So if a person has angina, right, they have stenosis of coronary vessels. If they try to same old for the heart, like trying to live at the normal flow lifestyle for the heart, if you may, the person will have angina, right, painful life conditions. But if you decrease the demand of the heart for oxygen, right, even if you have minimal flow, that minimal flow is just enough because you've basically like reduced the lifestyle expectations of the heart, okay. Now, what happens to the diameter or radius of veins in the setting of severe blood loss? Well, if you're losing blood, right, your cardiac output plummets, okay. If your cardiac output plummets, your bioreceptors are like, whoa, I'm not firing as much. Well, if you're not firing as much, remember I said that will cause a massive sympathetic discharge, okay. So if you're releasing more norepinephrine, you will clamp down on the alpha-1 receptors you find in venules, okay. That will cause a vasoconstriction. So by doing that, you're effectively decreasing the compliance of your venules, or you could say you're increasing the elastance of those venules. And when that happens, you're decreasing the capacitance, so you're storing less blood in your venules, in your veins, okay. So you're sending more blood to the heart, so your preload increases, okay. So the radius of veins actually goes down in the setting of severe blood loss. Okay, next slide. Why are veins more compliant than arteries? Just explained that in the previous slide. And the formula for compliance again is CVP, right? So compliance equals change in volume over change in pressure, okay? Now, next slide. Okay, so this one is kind of cool actually. It's just really annoying, but once you get it down, you'll be a maestro at understanding some bizarre things. So, that are actually relevant to your step 1 exam. If you're going through this podcast, you're basically going through the cardiology section of first aid for the USMLE step 1. But I'm just trying to give you context for many of those cardiac physiology concepts they outline in the textbook. Okay, so why is high output heart failure a feature of anemia? That's one question. It's a great question. Why would a patient with a JAK2 mutation have an increased risk of thrombotic events? So JAK2 mutation, I hope you're thinking about your myeloproliferative syndromes like polycythemia vera, okay? Remember, those people classically can get hepatic vein thrombosis that can present as a Budd-Chiari syndrome. So that's another question we have. Third question, what is true of total peripheral resistance in a patient with Waldenstrom's macroglobulinemia, right? So remember, this is an IgM monoclonal proliferation, okay? So why does the TP, total peripheral resistance, actually goes up under those circumstances? And we're like, why is that? We'll talk about that in a bit. 24-year-old female has unrelenting hypertension with a flank bruit heard on physical exam, right? So this is the classic description of a fibromuscular dysplasia. And basically, the last question is basically a leading to answer all these questions. What is the equation of pathophysiology that explains your responses to all these questions? Okay, so let's talk about the equation and then we'll try to answer all these questions. Okay, let's talk about the equation and then we'll try to answer all these questions. So I've already mentioned this equation already, right? So I said that there are two high yield equations you want to know that basically explain a lot of concepts relating to cardiovascular physiology. Okay, one equation is the P equals Q times R equation, right? So P, Q, R. That's an easy one to remember. Okay, so if you do a substitution, if you make Q the subject of that formula, Your Q, which is basically like your flow through vessels, is directly proportional to the change in pressure and inversely proportional to the resistance. Okay, so Q is equal to P over R. Okay, so I hope you're still with me at this point. And then the second equation I said is that, oh, your resistance is directly proportional to the viscosity in a blood vessel, and it's also directly proportional to the length in a blood vessel, right? So that should make sense, right? If you have more viscous fluid in a pipe, it's much harder for that fluid to flow, if you may. Okay, if you have a longer pipe, it's also much harder for things to flow, right? So you may be like, Divine, that doesn't really make sense. Think about it. Let's assume you should not do this. Okay, you should not do this. Well, let's assume you're trying to steal gas from a person's trunk, right? And you use a very short pipe, and you suck on the. You know what? Let me not use a bad example. Let's assume you're trying to get gas from your own car. Okay, and you take a pipe and you suck on it. You suck on the pipe, like, and you try to get some gas out, right? If it's a short pipe you use, the chances of you getting gas out are really high. But if you're sucking out of like a big, large hose, like a hose that's like, I don't know, like 20 feet long, you're not going to get any gas out because you cannot apply enough suction. Okay, so a very long blood vessel does not have enough suction, so it's much harder for blood to flow through those vessels. Okay, so resistance is directly proportional to viscosity and directly proportional to length. Okay, but it is inversely proportional to radius to the fourth power. And because this radius has the fourth power going for it, that should sort of tell you that that's probably the most important variable in this equation. Okay, but if you understand these equations, right, let's sort of make some parallels here. Right, so the first parallel we want to make is, why is high output heart failure a feature of anemia? Well, if a person has anemia, right, what happens to the hemoglobin in the blood? It goes down. Hemoglobin is a protein, right? So if the amount of protein in your blood goes down, okay, what's happening to your blood viscosity? Well, I hope you're saying that it goes down as well. If your blood viscosity goes down, according to that second equation, your resistance should go down because those things are directly proportional. And if your resistance goes down, what happens to flow through your vessels? It increases. Okay, so if you have a constant increased flow in the setting, like if your heart is constantly having to provide that increased flow because you have less blood viscosity, you can have a high output heart failure in the setting of anemia, right? So this is a classic step 1 question, classic medicine shelf question as well. Okay, now the second scenario is, why would a patient with a JAK2 mutation have an increased risk of thrombotic events? Well, the mechanism behind that is, if a person has a JAK2 mutation, for example, right, let's assume they have polycythemia vera. Okay, so polycythemia vera, remember in polycythemia vera you have a very high hematocrit, but your EPO is actually low. Okay, so don't mistake that with like an EPO secreting tumor like renal cell carcinoma. You have high EPO, but you also have high hematocrit with that. Polycythemia vera has low EPO with high hematocrit. Okay, so if your hematocrit is super high, okay, your blood becomes super viscous. If your blood is super viscous, the resistance in your blood vessels go up because those quantities are directly proportional, and as the resistance goes up, okay, your flow comes down. Okay, your flow comes down. And if you really think about it, if the flow or your Q through your blood vessels go down, right, are you thinking about varicose triad by any chance? Your SHE, like stasis, hypercoagulability, and endothelial dysfunction? So that S, stasis, if you have a reduced flow of blood, you have more stasis of blood, and because you have an increase in one of the factors in varicose triad, you have an increased risk of thrombotic events. Okay, so that's why you can get like a hepatic vein thrombosis with polycythemia vera, which classically on exams presents as a Budd-Chiari syndrome. Okay, and yeah. So what is true of TPR in a patient with Waldenstrom's macroglobulinemia? Basically the same thing with P vera. Okay, you have too much protein in your blood. In this case the protein is IgM. Okay, so you have a hyperviscous blood, so you have a big resistance. You have low flow. Okay, so your TPR is going up, the flow in your blood vessels are going up as well. Okay, so I mean they're going down, sorry. Okay, they're going down, and again, because your TPR is going up, right, your cardiac output is going down because your blood has to work much harder to pump that sludge. I mean, your heart has to work harder to pump that sludge. Okay, now if a person has fibromuscular dysplasia, right, again, their TPR goes up because their the radii of their renal arteries is going down. Okay, so a decrease in radius, right, is increasing the resistance. Okay, so that decreases flow through the renal arteries. Okay, and as you see on the later slide, that has certain implications with regards to hypertension. So slide 12, that is that later slide as it may happen. So for the last patient in the preceding question, what should be true of flow through the renal artery if angiography reveals 50% stenosis, right? So this will be a conceptual mathematical question you could get on your exam. Okay, so if you have 50% stenosis detected on renal angiography in a person that has fibromuscular dysplasia, okay, your radius is basically being chopped off in half, right? And if your radius is being chopped up in half, what's happening to the resistance in your renal artery? Remember, your resistance is inversely related to your radius. So that halving of your radius should increase your resistance to the fourth power, okay? So basically your resistance should go up to the by a factor of 16, right? So remember 2 times 2 times 2 times 2. So 2 times 2 is 4, times 2 is 8, times 2 is 16. Okay, so your resistance goes up by a factor of 16. And if your resistance is going up by a factor of 16, it should then stand to reason that your flow through the renal artery should also go down by a factor of 16. Okay, your flow through the renal artery should go down by a factor of 16. Okay, so basically if you wanted to be like, I don't want to think through so many variables, whatever happens to your resistance also happens to your flow. Whatever happens to your radius also happens to your flow. So a decrease in radius decreases flow. Okay, decreased radius decreases flow, but to the fourth power. Okay, don't forget that addendum. Now, as an aside, if a person has renal artery stenosis, right, so what should be true of their renin, right? So if they have stenosis of the renal artery, the afferent arteriole is not getting enough blood flow, okay, low flow to the afferent arteriole will activate your juxtaglomerular apparatus, your GG cells, okay? They secrete more renin, okay? So your renin goes up, okay? One of the jobs of renin is to convert angiotensinogen from the liver to angiotensin 1, okay? So your angiotensin 1 levels do go up as well, okay? And then if you get to the endothelial cells in the lungs, angiotensin 1 is converted by ACE, angiotensin converting enzyme, to angiotensin 2. So your angiotensin 2 levels should go up as well. Okay, if your angiotensin 2 levels go up, remember one of the functions of angiotensin 2 is to make its way to the zona glomerulosa of the adrenal cortex. When you activate that zona glomerulosa, you secrete more mineralocorticoids like aldosterone, so your aldosterone levels go up. Okay, so your plasma aldosterone to renin ratio will be normal in a person that has renal artery stenosis. Contrast that with a person that has Conn syndrome, okay, so an adrenal adenoma or adrenal hyperplasia secreting too much aldosterone. Your aldosterone will be super high. That will raise your blood pressure. That would negatively feed back at the level of the afferent arteriole, so you secrete less renin. So your plasma aldosterone to renin ratio will actually be higher in Conn syndrome, okay. And the analogous disorder in an older male will be renal artery stenosis, okay? Fibromuscular dysplasia is a cause of renal artery stenosis, but in older folk, they just call it renal artery stenosis, okay? And the relatively high eudocular finding here is AV nicking, right? So you can detect this on fundoscopic exam. I'll encourage you to look up a picture of this. It's actually pretty striking when you take a look. So if you see an old guy with unrelenting hypertension and they say fundoscopic exam reveals AV nicking, arteriovenous nicking, think about renal artery stenosis, okay? That may be a question where they don't even tell you anything about the brewery, okay? But if you see AV nicking, old guy hypertension, you really want to think about renal artery stenosis with that. Okay, now next question says a patient, and I know this has gone long, I apologize, we will be done with this quickly. This is the second to the last slide, and the last slide is relatively not involved. Okay, so question 13. Patient undergoes an nephrectomy for autosomal dominant polycystic kidney disease. Remember, ADPKD has an association with mitral valve prolapse. Okay. Also remember, it has an association with subarachnoid hemorrhages. Okay, from ruptures of berry aneurysms in the circle of Willis. Okay, so patient undergoes an nephrectomy for ADPKD, assuming sensitive measurements after surgery. What is true of total peripheral resistance, cardiac output, and heart rate? Okay, and what is the underlying pathophysiology and how does this relate to resistance? Okay, this is a very high yield board exam scenario. Okay, in fact, I believe you will find some like a one-liner mention of this in the nephrology chapter of your first aid book. So let's talk about this. Okay, but to talk about this, we'll have to talk about resistance. Okay, now if you remember back to college physics, again, don't hyperventilate. This should be fairly straightforward. If you remember back to college physics, if you have a pipe, okay, like one continuous pipe, okay. In fact, let me write down my thoughts as I'm going through this to make sure I don't screw this up, because it's relatively easy to actually screw this up. Okay, so if you have one continuous pipe, right, the flow rate throughout that pipe is the same. Okay, the flow rate is the same, right? So everything in that pipe, okay, is all going in series. Okay, and if you remember, if a person if you have resistors that are being arranged in series, you get the total resistance by just adding up the individual resistances, right? So like if you have like 3 resistors and R1 is 1, R2 is 2, R3 is 3, and those resistors are all in series, the total resistance will be 6, right? You just add up all those numbers. Okay, so if you notice, the total resistance 6 is bigger than any of the individual resistances, right? So 6 is bigger than 1, bigger than 2, bigger than 3. Okay, so the total resistance is bigger than the resistance of any of the blood vessels that make up that singular system. Okay, so if you're talking about like if you're talking about like singular flow from the heart through the aorta to your arterioles, to your capillaries, to your venules, to your veins, and back to the right heart, that's a series system. Okay, that's a series system. And that is also the same system that operates within a singular organ. Okay, so singular organ. So if you're just dealing with like, oh, I'm just dealing with the kidney, or I'm just dealing with the lungs, or I'm just dealing with the GI tract, for example. Okay, those are singular systems. Singular systems exhibit resistors that are placed in series. Okay, but in the body, if you're thinking about each of our individual organs taken together, those organs are actually all arranged in parallel. Okay, all our organs, think of them as being some kind of parallel circuit. Okay, think of them as being some kind of parallel circuit. So if you have a parallel circuit, and think of each of our organs as being some kind of resistor, okay, and you arrange that parallel circuit, you put resistors in parallel, how do we calculate the resistance under those circumstances? Well, if you remember in college physics, the inverse of your total resistance will be the inverse is equal to the inverse of R1 plus the inverse of R2 plus the inverse of R3. Right? So let's use real numbers with this. So it's like if you have 3 resistors, right? So like 3 different organs, and R1 is, I don't know, like 1, R2 is 2, and R3 is 3. Okay, 1 over the total resistance will be 1 over 1 plus 1 over 2 plus 1 over 3. Okay, the common denominator here should be 6. So in the numerator, we should basically have 6 plus, let's see, blah blah blah, plus 1 plus let's see, so the inverse of R1, so 6 divided by 1 is 6 times 1 is 6, divided by 2 is 3 times 1 is 3, oops, sorry, that's 6 plus 3, plus 6 divided by 3 is 2 times 1 is 2, plus 2, so 6 plus 3 plus 2, okay, so that's 11 over 6, okay, so the total resistance, remember you have to flip the equation, the ratio at the end, that's 6 out of 11, okay, that total resistance of 6 out of 11 is less than each of the individual resistances. Okay, so the total resistance is less than R1 or R2 or R3. So let me ask you a question. Now that we've done the math and talked about like how you calculate these resistances, if you have resistors being placed in series, when you add some new resistor, what happens to the total resistance? It should go up, okay, for a series circuit, because again, if you had like R1, R2, R3, 1, 2, and 3, and you add R4, which is 4, total resistance will go up, okay? But as you can see from the equation that we used for resistors that are placed in parallel, if you added an extra resistor, the total resistance actually goes down, right? So think about this. So 1 over 1 plus 1 over 2 plus 1 over 3. Let's say we add an R4 and make it 1 over 4. Common denominator now should be 12. So that's 12 plus 6 plus 4 plus 3, right? So we have 18 plus 4, that's 22, plus 3, that's 25 over 12. Okay, and then if you flip 25 over 12, that's 12 over 25. 12 over 25 is a smaller number than 6 out of 11. Okay, so right, 12 over 25 is a little less than 0.5. 6 over 11 is a little greater than 0.5. Okay, so when you add a new resistor to a series of resistors already in parallel, you actually decrease the resistance further. Okay, so again, that should potentially explain why, because arterioles and capillaries branch out a lot, you have like very good decreases in resistance, which decreases pressures. But back to this example we're talking about. We said add a new resistor to a resistance circuit in series, total resistance goes up. The corollary to that is if you removed a resistor from that resistance circuit in series, the total resistance goes down. Okay, but if you're going for the parallel system, if you add a new resistor, we said the total resistance goes down. We proved that mathematically. On the flip side, if you actually remove a resistor from a resistance circuit that is in parallel, the total resistance actually goes up. Okay, so it's like you're removing R4. You go from 12 over 25 to 6 over 11. So the total resistance goes up. Okay, so I said that the different organs in the body, they are basically arranged in parallel. Okay, so if a person gets an nephrectomy, you're taking out one of their organs. If you take out one of their organs, and we already established that these organs are arranged in parallel, okay, that decrease in that removal of one parallel resistor raises your overall total peripheral resistance. Okay, now if you want to integrate this with that bioreceptor business we talked about, that decrease in total peripheral resistance, right, that increase. So you're taking out one organ, you're taking out an organ like a resistor that's in parallel, so the total resistance goes up. Okay, so you have an increase in total resistance, so your TPR is going up. If your TPR goes up, okay, you have an increased blood pressure. That increased blood pressure will cause more firing of your bioreceptors, okay? And if your bioreceptors begin to fire more, that causes a massive parasympathetic discharge as a response. So your cardiac output should go down, your heart rate should go down, okay? Your heart rate is going down because through that parasympathetic discharge, through your muscarinic receptors, you have a decrease in the slope of phase 4 of the SA node potential, so your heart rate goes down, okay? And you also have decreased flow through your AV node, okay? And if your heart rate is going down, remember that your cardiac output is heart rate times stroke volume. As your HR goes down, your CO will go down as well, okay? So that is the pathophysiology behind that thing. This is one of those step 1 questions I can almost bet that many people will get wrong, okay? Don't be one of those people because you listen to this podcast. Well, I guess you read the first aid page, but at least you have the explanation behind that factoid in first aid and nephrology. Okay, so last question. A 66-year-old male with a 40-pack year history of smoking presents with severe abdominal pain and a blood pressure of 65/40. Okay, a pulsatile mass is palpated on abdominal exam. What is your diagnosis? What is your diagnosis? Hopefully you know this is a AAA. Okay, so an abdominal aortic aneurysm. So what is the most commonly involved vessel in this process? Well, it's the aorta. Okay, the abdominal aorta. Okay, the aorta is the most commonly involved vessel in this process. And the last question is asking about the pathophysiology behind this observation. So this is where we have to take a detour and discuss something known as the law of Laplace. Okay, the law of Laplace. Basically, the law of Laplace, think an easy way to remember the equation is to remember TPR. Okay, TPR, total peripheral resistance. So the T, wall tension, is equal to the pressure times the radius of a vessel. Okay, or you can remember the word pretty. Okay, all ladies are pretty, right? So P is in pretty, R is in pretty, T is in pretty. Okay, so whatever floats your boat. Okay, so if the radius of a vessel increases, what happens to the wall tension? The wall tension should also increase as well. Okay, and if you look at all the blood vessels in the body, what is the blood vessel that has the biggest radius? It's your aorta. Okay, so because your aorta has the biggest radius, okay, it should then make sense that it should have the biggest wall tension. Okay, and if it has the biggest wall tension, as you have more and more tension on that wall, more and more tension, that wall could eventually balloon out. You could get an aneurysm, and if that aneurysm, because think about it, right, it's sort of like bad in a sense, because as the wall of the aorta begins to bulge out more and more, you actually place in more and more tension on the wall of that vessel. It's sort of like a self-fulfilling prophecy, if you may. And the more tension you place, eventually you can't sustain increased tensions forever. That vessel can blow off and you can get a AAA. Okay, and remember that, so that's the pathophysiology behind the observation, that the aorta is the most commonly involved vessel with regards to aneurysms. Okay, and explosion of those aneurysms, because again, it has the biggest radius. Okay, so that's basically just an illustration of the law of Laplace. Now, the one thing I will say to that is smoking is the biggest risk factor for a AAA. Okay, so they may try to trick you on the exam into picking hypertension as the biggest risk factor, or like hyperlipidemia or whatever. Those are not the answers. Okay, the answer you want to pick is smoking. Okay, smoking is the biggest risk factor for a AAA. Smoking is also the biggest risk factor for a myocardial infarction. Okay, the biggest risk factor for an MI is smoking. The pathology that has hypertension as the big risk factor is aortic dissection. Okay, aortic dissection occurs from having hypertension as a big risk factor. Okay, so I know this was kind of long, but I think we illustrated a lot of very high yield concepts in this set. And basically, if you've gone through this, the first aid, cardiac physiology, at least many parts of it, especially all those nasty equations, should all make sense. Okay, so make sure you understand this. I promise you will pay off on your exam, because these things are very commonly tested. If you can reason through these scenarios, you should be well on your way to crushing your cardiac physiology portion of your step 1 exams. Okay, I hope I didn't make any errors with this. I think I try to correct myself whenever I misspoke. But if you spot any errors or you have any questions, again, the email is divineinterventionpodcast@gmail.com. Just reach out to me and I'll be more than happy to either make any correction. Again, I'm just a med student. I'm not a professor. So I'm not perfect. Okay, I try to be perfect, but I'm not. Okay, so if you have any questions or you spot any errors, just let me know and I'll be more than happy to help out. Okay, so have a wonderful day and all the best on your exams. Thank you.